Thank you for the kind introduction. I thank the scientific committee for the kind invitation. I'm so sorry I can't be there in person. My name is Dr. Fatima Dhaheri. I'm an assistant professor of pediatrics and a consultant physician in infectious disease and immunocompromised hosts. And in the next 20 minutes or so, I'm gonna hopefully give you a bird's eye view on infectious diseases and liver transplant recipients. So the objectives that I'm going to cover are the pre-transplant screening, pre and post-transplant safe living, pre-transplant vaccines, timeline of infections post-transplant, donor-derived infections, and I'm going to touch a little bit on EBV and PTLD, recipient-derived infections, post-transplant prophylaxis, and I'm going to end with a little bit on CMV, the transplant troll. And since I can't be with you there in person, I am happy to receive your questions via email that I'm going to leave at the end of the talk. So this figure, I'm sure, is well known to a lot of you. This is Dr. Thomas Sarles, and he basically pioneered the field of liver transplantation. And so this is a face that started it all. And I'm not going to go over the timeline here, but it all started in the 50s when we had the first liver transplant technique in dogs. And then Sarzo basically pioneered it in humans. And we shouldn't forget the figure on the right, Dr. Royal Khan, who basically introduced the idea of immunosuppression that really helped Sarles in his liver transplant practice, and is the reason why liver transplant recipients live longer because of immunosuppression. And so by 2013, there was 102 deceased donor liver transplantation performed in the US, but then currently, more than 40 years from the first liver transplantation, more than 1 million liver transplants have been performed in the world so far. And liver transplant survival within the first year is roughly 80 to 90%. So the survival has increased significantly. And in the United States, is the leading country for most liver transplants out of any country, nearly 7,000 per year. The second most active is China. And surprisingly, the third most active is Brazil, with a volume remarkably exceeds a lot of the European countries, which is amazing. And so I'm going to start with pre-transplant screening. So the role of ID physicians starts very early and includes infectious serologies based on organ-specific risk factors, patient risk factors, and community risk factors, managing any active or chronic infections before transplant, and risk stratifying patients to prepare them before transplant under the umbrella of safe living, which includes food practices, travel counseling, pet animal counseling, and lifestyle changes. And last but not least, administering important vaccines pre-transplant. So that's why I always tell my fellow consultants, please send your patients to me ahead of time so that I can manage them. I know that especially with liver transplant, this can be very tricky because a lot of pediatric patients and adult patients go urgently to liver transplant. So this is an example of infectious serologies workup. So I do want to bring it into your attention that this is based on North American guidelines. We really need regional local mapping of relevant infections instead of deriving it from North American European guidelines. A big example is we have brucella, very prevalent in our regions, and it's not part of the North American workup. And we don't have guidelines whether to send for brucella as part of routine screening. Now, I send it to patients if they have risk factors, if they have a camel herd, if they routinely drink unpasteurized camel milk, for example, but not universally. Pre and post-transplant safe living, we go over food practices, interacting with animals, environmental exposures, travel counseling. So I spend a lot of time with patients basically touching on those safe living practices, because this can wreck a fresh transplant. especially with food handling, animal exposure, environmental exposure. So examples of some counseling I do with food practicing include avoiding unpasteurized dairy products, avoiding raw food, handling of food prep and preparing for food is very important. Interacting with animals, I usually break the hearts of kids when I say you cannot bring a new pet. But if you have an existing pet and they're vaccinated, it's okay. Never handle animal litter, for example, and avoid certain setups like in barns or the birth of animals. Environmental exposures, I really want to explore or delve into what hobbies patients have, especially when it comes to gardening, because you are exposed to spores that can give you aspergillus. Certain hobbies like cave exploration in the US that can give you histoplasma and so on. So really delving into how patients live. And this happens pre-transplant and post-transplant. And then travel counseling. A lot of patients would ask me, I have this travel schedule, how soon can I travel post-transplant? It really depends on what, the kind of immunosuppression, if there's any rejection episodes, how is your cell doing in terms of lymphopenia, and where you're traveling. And if we can safely give you an activated vaccine towards your travel destination or not. This is an example of a family education sheet that we used to give out in my older institution in Boston Children's where I trained, and it basically goes over everything that I talked about. And this is something that we need to reiterate over and over again and answer a lot of questions involving life practices, because solid organ transplant is lifelong. So you need to make sure that patients are adapted to these life-changing practices as well. So next is pre-transplant vaccines. Very important to catch up vaccines and make sure patients are up to date with the vaccine schedules. In addition to exploring additional vaccines in the context of organ failure and dialysis, an example is like pneumococcal vaccine, travel vaccine. Now, the rule of thumb here is that inactivated vaccines should be given at least more than at least 2-week time frame pre-transplant, while live vaccine should be given at least 4 weeks pre-transplant. And this has to do with the kind of immunosuppression that you get at time of transplant. And so this is a rule of thumb. Now, if we can get patients long before they are listed and catch them up, then that's great. But if we are in an emergent situation and they say, for example, that this kid is deteriorating, we are expecting that they would need liver sooner rather than later, then we can use that rule of thumb. This is the table of recommendation of immunization of pediatric patients. This is also obtained from the American Society of Transplantation. I'm not going to go over it, but there are a set of vaccines that are recommended and set of vaccines that are contraindicated post-transplant, especially pre-transplant, depending on degree of organ failure, depending on if they are on immunosuppression to begin with, then we need to look into those certain vaccines, which I'm going to address in my second talk on the 6th of May. Now, in 2018, there has been proceedings of a consensus about live vaccines after pediatric solid organ transplant, and liver transplant is included here. And this is a multi-site center that's ongoing, and Boston Children's was one of those sites. And so because of the rising outbreaks of measles, the committee have looked into safely administering vaccines like MMR and varicella into select kidney and liver transplant recipients. And it really depends on timeline, immunosuppression, immunocriteria met. And basically they need to be, I don't know if I include in the next slide or not, but I'm definitely going to go over it in my second talk. But basically, it is select patients where they're at least on single immunosuppression. They don't have any cytopenias. They don't have any rejection episodes, and they're more than 1 year out of transplant. So very strict criteria, and I'm going to touch on that in my second talk. I did include it here, but this is basically group 2, proceed with the vaccine. Clinically well, do not meet criteria either in the red or yellow boxes, 1 year post-transplant, 2 months post-rejection episodes. And then there's certain criteria about the intensity of immune suppression criteria. So the steroids need to be at a certain dose, the tacro needs to be a certain dose, and the cyclosporin needs to be in a certain dose to meet criteria. And then you have the minimum immune criteria. Your ALC needs to be more than 1,500, and your CD4 needs to be more than 700. So very strict criteria, but this ensures that in select patients, you can protect them from measles. As you know, pre-2018, we don't give any live vaccines, but these practices now standard in a lot of big US centers sort of allows these select patients to be protected against measles and varicella. So this is a classic diagram where we teach trainees about timeline of infections post-transplant. We kind of think about infections post-transplant from a donor-derived perspective and recipient-derived perspective. So it really depends on where they present in the timeline, whether it's less than a month, between 1 to 6 months, and more than 6 months of the type of infections that they get. And so as an example, if it's less than a month, you think about donor-derived infections, but you also think about infections in the hospital that they can get, basically antimicrobial resistant species, any surgical complications from anastomosis, etc. But then when you get to 1 to 6 months, depending on if you are prophylaxed or not, then you get things like CMV, PCP, etc. And then more than 6 months, you kind of think about sort of your viruses more. I think I have more of a figure depicting that, but I'm going to go over it more in depth. But donor-derived infections, this is where the importance of OPO comes, and into recruiting transplant ID trained experts to screen out donors. So I work with the Emirates Organ Transplant Office, OPO, handling all deceased donors for that specific role. When I get a referral or a consult, we look into their epidemiological exposures, whether they're international donors, living donors, deceased donors, weighing risks and benefits of accepting donors with active infection versus the risk of death of the recipient on the waiting list. And so the transplant ID thumb of rule that I follow, this is not one catch-all, but this is sort of just the basic rule that I follow. But of course, there's a lot of things that go into a referral. But is there a bug identified? Is there resistant profile identified? Is there therapy identified? Are we able to treat the donor recipient successfully? You have no idea the amount of donors that were rejected by non-ID physicians. And when they come to me, I say, actually, we have a bug identified, we have a resistant profile identified, we have a therapy identified, we can treat both donor recipients successfully. And a recent example was an infective endocarditis with strep viridans, where that donor was rejected, but actually we were able to accept after me going over those criteria. So this is basically going over the data from the OPTN in the US over what kind of donor-derived infections that liver recipients get. And as you can see here, things like viruses and bacteria are the most, and then followed by fungi and mycobacteria. And really, it depends on in this example, when it comes to viruses, it depends on when you're testing. And so I always teach this to trainees, that you have that window where when you test, you get a false negative. So you need to make sure, when are you testing? And if you need to repeat testing, for example, when it comes to Hep B, if they're high-risk donors. So the expected donor-derived infections include CMV, EBV, hepatitis B virus, Hep C virus. In the US and a lot of European countries now, they match Hep B donors to Hep B recipients. I'm not going to delve into it in this talk. But then the unexpected donor-derived infections are things like HIV, because now we're very good at screening that. West Nile virus in the US, because we also screen for that. And tropical viruses like chikungunya, dengue, and Zika. And so because CMV and EBV are expected donor-derived infections, I'm going to touch a little bit on them. So this is just a table from the OPTN about importance of recognizing donor-derived infections, because if you diagnose, and that's the importance of ID trained physicians in transplant ID, Because if you think that this is a donor-derived infection, then you need to alert the OPO, and the OPO needs to alert every recipient that got an organ from that donor. So it's very important for tracing. So a little bit about EBV and PTLD. As you can see here, when we think about EBV and PTLD, there's risk stratification of different organs, and things like the heart or heart-lung are really, really high risk, especially lung heart. As you can see here, 16% after 5 years. PTLD in general is rare, but when it happens in those high risks assault organ. Liver, I would say, comes in the middle. So things like kidneys lower than the liver. There's no intestine here, but things like intestine is higher than the liver. So it really depends on the amount of lymphoid tissue that your organ you transplant with your organ. And the reason why it's high risk in the heart, because you also affect the thymus, which increases that risk because of lymphocytes and lymphopenia. The risk factors for PTLD includes EBV seronegativity at the time of transplantation. So that means your recipient is immune. Any active primary EBV infections at the time of transplantation. If you use any T-cell depleting agents for transplant, the type of immunosuppressive drug regimen intensity, the type of organ transplant, and the age, CMV co-infection, and things like BMT, like chronic graft versus host disease, extent of HLA mismatch as well. And so the first thing, the risk factor is important, EBV seronegativity. So that's why ID physicians ask for serostatus, because this is how we risk stratify, not only in EBV, but in CMV and other viruses. So it's very important to know the serostatus, of donors and recipients. So when it comes to recipient-derived infections, very important for ID physicians to be involved. So we talked about why it's important for ID physicians or transplant ID physicians to be involved pre-transplant, but why is it important to be involved post-transplant? So, and this part should be set way ahead. So if I know the recipient status pre-transplant, then I can give them the prophylaxis plan. So you need ID trained physicians post-transplant to guide you in appropriate prophylaxis, both viral, bacterial, and parasitic, identify risk factors for recipient-derived infection, identifying early donor-derived infections, identifying antimicrobial resistance, and outlining the plan for two things: empiric antimicrobial regimen. So you cannot just cover everybody with piptazo. You need to look at several factors, and assessing plan for targeted antimicrobial regimen as well. So this takes a lot of delve into the patient's chart and assessing the patient as well. So this is the timeline of infections. I showed you a similar graph, but I divided it into donor and recipient. So this is only recipient. And same thing, this one is divided into less than 4 weeks, between 1 to 12 months, and more than 12 months. I don't know if you can see my cursor here, but you can see that especially, I'm going to give you an example of the fungal infections. Candida peaks in the first 4 weeks, but then kind of decreases, but then Aspergillus and other molds peak beyond the first month. Why is it important? If you suspect fungal infections and the patient is, let's say, 2 months post-transplant, and your first thing is, let's start fluconazole. Well, fluconazole is not an active Aspergillus agent. You need to think about azole-specific active Aspergillus agents. Same thing about bacterial infections as well. So that's why it's very important to know what kind of infections and the timeline that happens. So the timeline of infections is dependent on prophylactic measures. So if you, for example, start CMV prophylaxis, then you get late CMV infections. The kind of conditioning regimen used, immunosuppressive regimen, rejection episodes. Every time you get a rejection episode, you kind of push the timeline back. Basically, they kind of go back to square one. Environmental exposures, pre-transplant vaccines, colonizer organisms, and pre-transplant chronic infections. Now, the father of transplant ID, Dr. Bob Rubin, describes this term, net state of immunosuppression. So your liver transplant patient is not immunosuppressed because he's a transplant patient. he is immunosuppressed because of a lot of factors, and that includes the immunosuppression, co-infections, age, nutrition. So a lot of things go into this net state of immunosuppression. It's the role of ID, physicians trained in transplant ID to assess for that net state of immunosuppression. This is just an example that I like to give, just showing that not all transplants wear the same hat. So on your far right, you see a graph comparing solid organ and BMT. And you can see that the sort of onset of fungal infection is different. And then it stops in BMT and continues in solid organ. And the reason is for BMT, hopefully, if it's a successful BMT, you expect a reconstitution. And if you expect reconstitution, then they turn into immunocompetent host when they get the new immune system. That's not the case with solid organ system, where you are immunosuppressed for a lifelong. But I want to point out here, even within the solid organ transplant, between, for example, liver and kidney and lung and heart, different risk factors for fungal infections. And this is just fungal infections, because this is the same with viral and bacterial. In the liver, if I can draw your attention, you can see that you have a lot of candida. If you compare this with the lung, for example, not sure if you can see my cursor, you can see here that Aspergillus is more than candida. And the reason is because with the lung transplant, you're exposed to the spores that is inhaled. That's why the first thing you get is Aspergillus spores, rather than the liver, for example, where they're more connected to the gut and they get gut translocation with candida. Very important, right? Because you cannot just, do fluconazole for everybody. You need to know the kind of risk profile that these organs carry. Post-transplant prophylaxis, so very important. And these are the tenets of post-transplant prophylaxis in liver transplant. So you need to prophylax against ECP, the drug of choice is trimsulfa, Bactrim, either daily or 2 to 3 times a week dosing. And Bactrim also offers toxoprophylaxis and partial cordia prophylaxis as well. And the duration is anywhere between 6 months to 1 year. And this depends on what immunosuppression regimen this patient is on, any rejection episodes, etc. CMV, very important, GAN and Valgan. It's 3 months intermediate risk for intermediate risk and 6 months for high risk. I'm gonna go over that in a little bit of details. HSV and VZV, if they're not receiving CMV prophylaxis, then acyclovir should be used 2 to 6 months or during periods of lymphodepletion treatment of rejection. Acyclovir is not a good CMV prophylaxis though. But if you don't have any issues with CMV, for example, then and you want to prophylax against HSV, then you can do acyclovir. Okay, so a little bit about CMV. Why is it important? We call CMV the troll of transplantation. That is the term coined by Dr. Henry Balfour. And why is it troll of transplantation? It wreaks havoc in transplant, not just in liver, in a lot in either other organ transplant, BMT. CMV has direct effects and indirect effects. The direct effects of CMV is the CMV infection and organ disease. CMV colitis, CMV pneumonitis, which is horrible and has a high morbidity and mortality, CMV retinitis, etc. But then you have the indirect effects, and that's what makes CMV very interesting. CMV can lead to graft rejection and loss of the organ. And it can actually stimulate rejection, GVHD and BMT, and actually sustain immunosuppression leading to infection. CMV itself is immunosuppressive, which is interesting to think about, right? Because, and we've seen when they have CMV infection, you have other viral reactivation, you have other bacteremia going on in the background. It's fascinating to think about. And then induction of autoimmunity and autoimmune disease. Very fascinating. CMV actually messes up with the immune system to the point that it not only immunosuppresses, but actually causes autoimmunity, which you don't want autoimmunity and autoimmune disorders in patients who are already fragile and immunosuppressed. So this is why I have so much respect for CMV. All ID physicians have so much respect for CMV because of this. So CMV and solid organ, the risk factor for CMV and solid organ transplant depends on past CMV infections, new CMV exposures, degree of T cell impairment if you use T cell depleting agents in your induction regimen, and type of organ being transplanted. About 20 to 30% of adult transplant patients are CMV IgG negative, and that is high risk and at greatest risk for primary infection. And the donor organ is the most common source, but obviously, if you have blood transfusions around the time of transplant, that's also another route of infection. I've shown this figure before, but the thing that I wanted to point out is that if you do not prophylax with CMV, you get it early, but if you prophylax, you still get it later. So you cannot stop thinking about CMV even if you prophylax. That's why surveillance is super important after you stop prophylaxis. And so some of my concluding slides, again, about CMV, the concept of CMV serostatus. So if you're donor positive and recipient negative, that makes you high risk. And if you're high risk, then that means you need to go to 6 months duration as opposed to 3 months duration. Other things that you need to look at is type of immunosuppression, and organ transplants that are considered high risk are things like lung, pancreas, and intestine. But if you have liver and you have donor positive, recipient negative, you're still high risk. And so this just shows you what is high risk, what is intermediate risk, what is low risk. But when it comes to liver transplant, obviously, if your liver, intestine, liver, pancreas, that increases your risk. Looking at serologies alone, if you're donor positive, recipient negative, you need 6 months. If you are recipient positive, then you need 3 months. So very quickly, CMV and SOT. So we follow universal prophylaxis at risk solid organ starting within 10 days of transplant. Ideally early on in transplant, but if you have any complications, you can push it a little bit further. Valgan is the most commonly used drug for prophylaxis, and like I said, when you start this prophylaxis and you end, you can result in late onset CMV disease. So I think I'm running out of time, so I'm going to conclude here just to drive the point home. High risk is donor positive, recipient negative, and intermediate risk is recipient positive. One is 6 months and one is 3 months. This is again the father of transplant ID, Bob Rubin. We talked about the predictable timeline after transplant, which was his concept, and the next state of immunosuppression as well. He actually passed away in 2018, so that can just show you how the field of transplant ID is fairly young. He practiced in the Brigham. And this is my late mentor, Dr. Francesco Mari, who was actually Dr. Rubin's mentee. And he taught me everything I need to know about transplant ID. And he was the one who had me also train, because I trained in both Boston Children's and the Brigham. And one of his sayings is don't cover, discover. So don't just start antimicrobials hoping that things will go away. You need to uncover what is going on. And so that is a mantra that I lead in my practice and life always. And so I thank you so much for your attention, and I welcome all questions at my email. I'm part of the Emirates Infectious Disease Society, so we love for you guys to join us, register to be members. We also have a Twitter account where we post a lot of ID pearls and events, and so we welcome you to follow you there. Thank you so much for the committee, and have a good day.